between the obesity problems we have in our country and our lifestyle issues, you can imagine that there are a variety of metabolic problems. So we're taking a look here at the September 1st issue of JACC, and the Cardiometabolic Health Alliance is working towards a new care model for the metabolic syndrome. You think you know metabolic syndrome, but check out this paper because there's some important new things to think about. To help us with that is Dr. Laurence Sperling, who is a professor of medicine and the director of the Center for Heart Disease Prevention at Emory University School of Medicine. First, let's start with the basics. The Cardiometabolic Health Alliance, what is it?
Yeah, I've been very fortunate through the American College of Cardiology over the last several years to be the chairman of the Cardiometabolic Working Group. And it's really exciting that the ACC has taken on cardiometabolic risk and concern for diabetes as a leader in joining organizations to create a strategic plan for the future. The Cardiometabolic Alliance started out as an alliance between 4 organizations: ACC, National Minority Quality Forum; ABC, the Association of Black Cardiologists; and ACE, the American Association of Clinical Endocrinologists. And this partnership led to the first ever cardiometabolic think tank ever held in the United States. And we held this at the Hart House in Washington, D.C. last June of 2014, with over 20 organizations. And we purposefully brought in partners across the board in medicine and recognized that as cardiovascular specialists, we often care for people with metabolic risk and with diabetes, but to have comprehensive care and think about new models of care, right. We certainly cannot embark on this journey alone.
Now, in this paper, you're really taking a look at the best from this think tank, correct?
Yeah, what we tried to do in the think tank was purposefully, through the course of the think tank, we started out as, first of all, defining cardiometabolic syndrome, and at the end of the think tank, we actually thought the best term to use is metabolic syndrome, not cardiometabolic syndrome, because cardiometabolic focuses on one area of concern in this population, but really we need to understand that metabolic risk and the metabolic syndrome impacts the whole body.
Well, the important thing is, while many people think they know about the metabolic syndrome, and I certainly have studied it and reported on it for years, in reading your paper, there are some changes. There are some things that we need to think about now that we didn't before. Let's talk about those.
Yeah, so during the course of our think tank, we focused on a synthesis of 3 main areas. We focused on what we call affirmed concepts, concepts that we thought the literature supports pretty strongly. But what we also focus on were emerging concepts, thinking out of the box. And these emerging concepts were not only in how we think about the metabolic syndrome, and one of the things we proposed was thinking about it in terms of stages of the syndrome. Hopefully an important concept that will be utilized from this point on. And we also focused on key take-home messages. The staging part,
I mean, we stage everything else. I mean, heart failure has stages to it, for heaven's sakes, and metabolic syndrome, it makes perfect sense.
Yeah, as we look at somebody with metabolic risk, and by the way, the metabolic syndrome, although it is very common, 1/4 of all Americans by definition have the metabolic syndrome, 40% of people over the age of 60, we usually don't make this diagnosis, and it's a little perplexing why we don't. Is it that we're not connecting the dots, or we're not recognizing that often patients with slight abnormalities and multiple risk factors, if we put those together, that really accelerates the risk of these individuals. Cardiometabolic risk, or just metabolic risk in general, is really one of the reasons we're seeing more premature cardiovascular disease in our country.
One of the new concepts that emerged during the think tank discussion that caught my eye was that METs should be classified by subtype and stage.
Yeah, so in terms of subtypes, we need to realize too that these subtypes can have overlap, but we describe several subtypes. We described a subtype focused on insulin resistance, a subtype focused on cardiac risk, on lipid risk, and then the last one was more on systemic risk. For instance, you can have non-alcoholic fatty liver disease, and that's a manifestation of metabolic syndrome. You can have sleep apnea. In our paper, though, we also described what are stages of metabolic risk, and similar to heart failure, These stages start at stage A, and stage A is you have risk for metabolic syndrome, but not yet. And that risk can often start at the time of birth. That risk can be genetic, that risk can be related to culture, environment. And so at stage A, you're at risk, but yet to develop even one risk factor. Stage B, you've developed at least one risk factor, but by definition, you don't have the syndrome yet. And then stage C, you have the syndrome. So at least by the NCEP definition, 3 out of 5 criteria, which include central obesity, low HDL cholesterol, hypertriglyceridemia, insulin resistance, and at least pre-hypertension. And then stage D is that you have the syndrome, but you have evidence of end organ damage. Really, we wouldn't want to wait until our patients get to stage D, but if we look at what happens in clinical practice, that is usually when patients come to our attention, they have a fatty liver that might be noted incidentally on a CT scan, or they have sleep apnea and then atrial fibrillation as a result of their sleep apnea, and now they come to the cardiologist. They have metabolic syndrome and insulin resistance, and really their first presentation is often an acute vascular event, whether it's a stroke or a heart attack, and at that point somebody makes the diagnosis of insulin resistance or type 2 diabetes.
You also talk about improved metrics to define high-risk obesity.
Obesity itself is quite interesting, and I personally think that obesity itself affects all the parts of the body, but how do we understand what is unhealthy obesity and if there is such a thing as healthy obesity? Here, as we understand the evidence, healthy obesity may just be a time point in an individual with metabolic risk who has not quite transitioned into full-blown metabolic syndrome. There's a concept called the ticking clock hypothesis, and this means that sometimes, and in certain populations, those of South Asian descent, for instance, a slight bit of visceral fat, and that visceral fat might not show so much in the belt line, but that visceral fat, 5 pounds of it, could change what's happening inside. Inflammatory markers, markers of oxidative stress, that changes the biology and the signaling. And when that clock starts ticking, and in America right now, for the very first time, we are seeing in our children more type 2 diabetes than type 1 diabetes. So recognize this clock starts ticking when you're 8 or 10 years old, and it's ticking along for a few decades until that individual comes to the attention of their medical practitioner as somebody at risk. That risk has been occurring over time.
So in terms of the clinician, we're working towards a new care model for the metabolic syndrome. For right now, what's the number one thing that a doctor can do? Recognize
well,
metabolic
in the
syndrome?
current structure of healthcare in the U.S., which is transforming rapidly, the most important thing that a doctor can do is identify somebody either at risk for the metabolic syndrome before they go through the actual stages of diagnosis, or at least make the diagnosis of metabolic syndrome, which still is greatly under-recognized. So don't tell your patient you have borderline high blood pressure, you know, your cholesterol is a little elevated, and by the way, your blood sugar is 110. Have a meaningful discussion with your patient about what those factors mean. The cluster of those factors, they actually multiply the risk of your patient. And you could have a meaningful discussion based upon the data from the Diabetes Prevention Program, which means that it doesn't mean you have to start medicines right away, but you should focus on comprehensive lifestyle and behavioral factors, walking 30 minutes 5 times a week, a healthy dietary pattern, losing about 5 to 7% of their weight. That alone, we know, is about a 58% reduction in the development of diabetes, twice as good as a drug, metformin.
And once you know that there's a patient who's at risk or moving towards those stages of meds, then you've got your structured lifestyle intervention, optimal use of pharmaceuticals, including combination therapies, and appropriate consideration of surgery, which is another thing you bring up in the paper.
Yeah, so bariatric surgery, obesity surgery is a last resort. I heard it in one of the presentations today at the ESC here in London that in order to be qualified for obesity surgery in England, your BMI has to be above 50. That's quite large.
Yeah.
Now, that shouldn't be a primary population-based strategy for addressing the metabolic syndrome and cardiometabolic risk. Obesity surgery, though, has taught us some important lessons that if we take away that obesity, we can take away the metabolic risk and those risk factors and improve the outcome of individuals after surgery. Ideally, what we'd like to do is focus on it from a healthcare behavioral standpoint, healthcare delivery standpoint, and not wait until people have BMIs of 30, 40, and 50 to have to do surgery.
I mean, we did a cover story on bariatric surgery just a few issues ago. If you can find it, look it up. It was a fascinating one to create. So please go to JACC and take a look at the working towards a new care model for the metabolic syndrome, which is in the September 1st issue of JACC. And for Cardiol Source World News, I'm Executive Editor Rick McGuire.